Welcome everyone to today's webinar, our first of 2023. It's on the World Falls Guidelines. Today's webinar is facilitated by the Loop Fall Prevention Community of Practice. My name is Michelle Dukeman. I am the Knowledge Translation Coordinator for the Fall Prevention Program at Parachute. Before we begin, we'd like to start today's presentation with a land acknowledgement. Today, we respectfully acknowledge the land on which we live and work as the traditional, ancestral, and unceded territory of the Indigenous people, Canada's First Nation, Inuit, and Métis people, whose presence reaches back to ancestral time. We respect and affirm the inherent rights and title of Indigenous people of Canada and declare our respect of Indigenous elders, past, present, and future. I would ask that everyone takes a moment to themselves to acknowledge the land where they currently reside. Next, I'll cover a few housekeeping items. During the webinar, if you have questions about the technology, please type them into the chat box. My colleague Marguerite will be monitoring this space. If you have questions for our presenter about the webinar, please submit them through the Q&A box. They will be answered at the end of the webinar. You'll be able to view questions you have asked, but not questions posed by others. And this webinar is being recorded, and a link to the recording will be sent to all participants in about 1 week, along with the link to the presentation slides. I know many of you on the line are already Loop members, but for those who are not, we encourage you to sign up. Loop is the online communication platform for the Fall Prevention Community of Practice, and members use it to connect with each other, problem solve, and discuss how to implement evidence-informed and promising fall prevention practices. Listed on the side here are just a few of the services that Loop provides. And as a reminder, the recording link and the presentation slides will be posted on Loop in a few days. I'd now like to introduce our presenter, Dr. Montero-Odasso, professor and faculty scholar at the University of Western Ontario and director of the Gait and Brain Lab at Parkwood Institute. Dr. Montero-Odasso served as vice president of the Canadian Geriatrics Society and chair of the Global Guidelines for Falls in Older Adults Initiative. If you'd like a full recap and a bio of our presenter, you can find that on Loop. So without further ado, I will turn it over to our presenter, Dr. Manuel Montero-Odasso. You may now share your screen.
Thank you very much, Helen, Elio, Michelle. And first, I would like to thank Alain Gagnier and the Parachute organization for inviting me to this important webinar. I'm going to start sharing my screen to present my slides. And I planned this webinar to last around 40 or 45 minutes, so we can have enough time for questions that the audience may have. I'm Manuel Montero-Odasso. I'm professor and faculty scholar in the Department of Medicine and Epidemiology and Biostatistics at the University of Western Ontario in London, Ontario, but also have been chairing this international initiative, the World Falls Guidelines for Prevention and Management. So those guidelines, the summary paper, which is around 35 pages, is already published, open access and aging, so you can go there. So this presentation will not replace, I will say, the rigorous details in the paper, but would like to highlight how we get to this and which are the important key points of our guidelines. I don't have any important conflict of interest to disclose, except all the agencies that pay the bill of my research and the funding for different organizations that help me with my clinical activities and research. Sir Bernard Isaacs is considered one of the fathers of modern geriatric medicine. And he has a lovely book, the name is The Challenge of Geriatric Medicine, in where he speaks about several geriatric syndromes, including falls. And when he's speaking about falls, he starts saying that it takes a child 1 year to acquire independent movement and 10 years to acquire independent mobility. For example, the ability to cross the street alone. And an old person can lose both in a single day after a fall. I think that quote encapsulates the tragedy that may happen after a fall in an older individual. Why we need guidelines? Well, we do know that falls in older adults are very common, affect independency, and are associated with increased morbidity, mortality, and healthcare costs. I don't need to remind this to this audience. But interestingly, while contemporary trends in chronic diseases show diminishing important, I will say, hazards in diseases like cardiovascular diseases, even cancer, despite the aging population, falls and related injuries are still increasing. Hip fractures are decreasing if you adjust relatively for the amount of people, but falls are increasing. So falls and related injuries under epidemiological point of view is one of the few chronic diseases, or I would say syndromes, they are increasing. And current clinical guidelines for organizations or societies vary substantially in their recommendations across countries and settings, and there's a lack of a standardized approach. So our mission was to create a set of the standardized clinical practice guidelines for fall prevention and management that can be adapted and used in different settings and countries. And we have several goals, and I like to define a goal, and the way I define myself a goal is a dream with a deadline. You have an important dream, you want to do it, and you put the deadline. That was our goal. And in this regard, we wanted to reach global consensus and updates on clinical practice guidelines. We wanted to incorporate in those guidelines a person-centered approach, perspective from patients and caregivers that were lacking in previous guidelines, and recent development, particularly, in e-health and technology. We wanted to address the difference between different settings and countries. And we want to provide also toolkits and resources. This initiative started in 2019 during the World Congress of Falls and Postural Stability that was held in Kuala Lumpur, in where around 10 to 12 experts, myself included, in falls prevention, we came out with the plan, do we need new guidelines? Can we create those guidelines with a global perspective? And this initiative started that day. So as a first step, I presented during that conference the preliminary result of this systematic review and meta-analysis that is already published in JAMA Open, in the Journal of the American Medical Association, in where we try to rigorously, systematically review all current published guidelines about falls prevention management and to address commonalities, challenges, variations, and other problems in those guidelines. In our process, we detected 15 high-quality guidelines, and we used the agree-to score to determine high quality. A cutoff of 75% of the agree-to score was adopted as high-quality guidelines, and we got guidelines from the United States, the seminal AGS, BGS guidelines from UK, from Canada, France, Korea, Australia, and Ireland. The thing we found is the majority of the guidelines utilize an algorithm to do a stratification of risk, and the main question was later about falls history, previous falls history, and gait and balance problems. That was common in all those guidelines. Also, we found that the majority of the guidelines as management of falls, they do recommend physical exercise, medication review, modification of environmental problems, and addressing cardiovascular issues, particularly for syncopal falls. Interestingly, recommendations across guidelines were inconsistent about vitamin D supplementation. Should we provide vitamin D supplementation? Which dose? To whom? The use of hip protectors or not to prevent falls and related injuries. How we manage people with cognitive problems, or if there is any cognitive training to those with cognitive impairment to prevent falls. Inconsistency about the use of wearable or not in digital technology, but also inconsistency about education to prevent falls. Who should be educated and how? Interestingly, applicability of the guidelines was insufficiently addressed in all those guidelines. So there were not, I will say, clear guidelines how to apply, except I will speak later about the STD project. And all the adults' perspectives was lacked in the majority of the guidelines, and none of the guidelines has a panel of people with living experience in falls in order to peruse and to provide feedback in the recommendations. So based on those gaps, we wanted to create new guidelines, not only expanding the new knowledge and the new updates happens since the seminal 2001-2011 AGS-BGH guideline, but also to address those gaps. So how we can get this done, we said at the moment, and how we can address those gaps? Well, the first step was to publish how we want the methodology to address this gap, and that was published in Age and Aging in the New Horizons category, and this is available online, also open access. But basically, it takes a lot of people, it takes a village. Probably you know this expression that is coming from some African communities in where people and the society address that taking care and nurturing children is not only a work of the parents, sometimes it's the work of the complete village. And here, in order to do these guidelines, to nurture these guidelines, we believe it takes a planet. We got a lot of people involved. This is just a screenshot of our international Zoom meetings of our steering committee. And you're going to see that our initiative, when we started, and that was based on several networking activities we got in our Canadian Geriatrics Society and other societies, we recruit 96 world expert leaders for around 40 countries with the support and preliminary endorsements of 36 societies and agencies. So, and besides those 96 world experts, we created a steering committee with 25 scientists and clinicians working in falls prevention worldwide. And in order to address those initial gaps we detected, we assembled 12 working groups and one cross-cutting team. Initially, now we have like 17 groups. And we started doing additionally 11 systematic reviews and meta-analyses to address those gaps we detected in that systematic review we published in JAMA. But basically, the specific aim of this initiative was to update the existing recommendations based on the new evidence, but we want to use a comprehensive literature review and grading of the evidence. We want to incorporate this new evidence. We want to grade that recommendation. But later on, not only we wanted to base on the evidence, but we wanted to get some international consensus using a modified Delphi process that took several months, using a worldwide expert panel that we create that includes 300 members across the planet. And at the end, a voting to reach consensus. So basically, our guidelines from the beginning wanted to have 5 core elements. Overall recommendations for everyone to reduce falls. We wanted to focus in the assessment to identify which are the tools suitable in different settings, countries, environments to assess risk of falls, but to enable a center-based approach. We wanted to do risk stratification. Do we need or not? That was a discussion I'm going to expand later on. We wanted to address also which are the interventions that work and which interventions they don't work, and what's the recommendation according to the setting and the population. And also, we wanted to provide as much as possible a personal approach to customize diagnosis, management, including not only medical condition, but also values of the patient or the person with the experience of falls, which are the preference, which are the individual needs. And that was a lack in previous guidelines. So we look for key stakeholders, and we create also a panel of older adults. In an international panel of older adults, they're going to peruse our guidance, and those older adults should be people experiencing falls or being caregiver with people of falls, and everyone over 65. Again, based on this 12 areas detected, we created these 12 working groups initially, but also we create some ad hoc groups for areas that we didn't detect a gap, but we needed a group to review current evidence. For instance, issues about the role of dizziness or vertigo in falls. There's no new evidence about that, but we needed a working group to peruse the evidence and to provide some recommendations and all. So we have several ad hoc groups besides those working groups. We create also an algorithm committee in order, based on those recommendations from the 12 working initially group plus the other groups, how we can put this in an algorithm to help the stratification and management. And we address, and we wanted to have special chapters about special populations or emerging areas, right? How we deal with people with cognitive impairment, how we live with people having Parkinson's disease or stroke, what about technology and e-health, what about frailty and sarcopenia, and so on and so on. So this is a snapshot of our website in where originally we have these working groups. You can see the title of the working group. You can see the leaders of each group in the working group. Probably some of those leaders are attending today to this webinar, but as you can see, they are very well-renowned international experts being the leaders. So besides, and behind those leaders, there were teams, sometimes reaching 25 people, for example, in our team concerning multifactorial intervention. We have several leaders here, as you can see, but we're 25 people working with us in systematic reviews and meta-analysis. So this is only the snapshot of the 96 leaders and key experts, but this was an endeavor that includes hundreds of people internationally. And we're very proud that we're able to create a cross-cutting theme that was helping each working group to provide the perspective from a panel of older adults about what we're doing. And we got very interesting feedback. And in fact, we modified several recommendations based on the feedback provided for our panel of older adults with lived experience of falls. This is a very busy slide, but I'm going to have some animation in order to address how was the process in order to get this done. As I said, we started in 2019, but the goal was to have the final product in September 2022, because we got an invitation to present the world guidelines during the European Union Geriatric Medicine Conference at the main keynote and plenary talk in September 2022 in London, UK. And in general, that conference reached between 6,000 to 8,000 people. So we have a very hard deadline in 2019 by September 2022. And of course, in the middle of the pandemic occurs, but everything went well, fortunately. But basically, after detecting the gaps and the desired evidence, we create those groups and we do the static review doing literature searches and PubMed, and we identify that evidence. And we use the GRADE system in order to score or evaluate that evidence. And the GRADE system is a system that not only takes into account the actual, I would say, rigorosity of the evidence, but also the recommendation of the experts. So you can have a strong recommendation with a strong evidence or weak evidence. And similarly, you can have a very, I would say, weak recommendation with lower level of evidence. So, and that is the way that the GRADE system works. The way we modify is when the review or the systematic approach of the meta-analysis was not able to find evidence, or the evidence was not there yet, but there was a strong feeling for the expert that the recommendation in that regard was important. We qualified that recommendation as an expert recommendation. So the evidence is not available, or the evidence is not there yet, but we believe this is important to do. So that was great as an expert recommendation. And based on this evidence and the recommendations for each group, we come up with these preliminary recommendations, and we get the complex Delphi process in where we got this community across the planet reviewing in several rounds our preliminary recommendations. And when we incorporate the feedback, done by our steering committee, composed by 25 members, we come up with the revised recommendations, incorporating all these feedbacks, including the figure of the patients or people with the living experience falls. And after those revised recommendations, we polished them and we did a web-based voting to get the final recommendations. So, and this is a very busy Gantt chart with the process and timeline, but basically, in winter 2021, we were able to draft the preliminary recommendation for all the working groups. And later on, we get this Delphi process with 3 rounds, getting feedback from all the experts, and we incorporate the figure and we send to them the recommendations again, and we get feedback again, and so on. There were 3 rounds. And we create those revised recommendations in the spring, summer 2022. And at that moment, the writing committee started writing the paper or the main document with some placeholders. And at that moment, in where the revised recommendations were almost finished, where algorithm committee start deliberations, how we create a new algorithm for fall stratifications. And also we get a second rounds of comments from the other adults panels. And after that, we go into the weight-based voting, in where the recommendations that get more than 80% of approval were approved. Those that were get less than 50% of the voting were totally rejected. But those who were 50 to 90% or 80%, they were revised again to see if there is any modification we can do. We returned to the working groups and we went to the Delphi process again. And we got the final recommendations. And that is, for example, a tabular summary, how you're going to see the recommendations in the paper. For example, from the group number 1, about gait balance, they say stratification. We should use gait speed and time up and go. It's a strong recommendation with good evidence. About time up and go, it's a strong recommendation with weak evidence, and so on and so on and so on. But I want to, so beside this methodology, I think it's important to show the rigorosity we have taken to do all these, and that took several years. And when you go to the website where our paper is open access, the 30-something pages, the full document is 300 pages, and the full document has to attach to each recommendation the grade evidence to action table. So you can, I will say, dissect by yourself how we come up with that evidence about strength or not of the recommendations. But we have around, I think, 80 recommendations. I'm going to focus here with the 10 key messages and what is different and what is new in those guidelines. But basically, give me a second. You can see here that one of the new things we wanted to do is that in the past, people with low risk were considered that the risk was so low, the risk was so low, the only thing we need to do is to reassess them at a prudential time. A year, 2 years, depends on the guideline you read. Evidence shows that older adults with low risk, still 1/3 of them experience fall. And according to some cohort studies, 70% of those falls have an injury. So those falls are not benign. So here you can see, if you are considered low risk because you don't have any falls and you don't have any problems in the gait of balance, the goal is primary prevention, and still we should offer to them exercise and education about falls. And that is backed up with very good evidence that you can read the full evidence in the guidelines. The other thing we address here is a group that was missed in some of the guidelines with the intermediate risk. So those, they have a fall, but perhaps that fall is the first fall in their life. The severity of the fall is considered low, and we're going to define how we speak about severity. And they may have some gait and balance problem. They walk normally, but when you go to the assessment, you detect some gait and balance problems. And evidence show that those individuals have a higher risk than the low risk. Perhaps the risk of fall is around, I will say, 35 to 40%. But evidence showing those particular individuals are those that benefit the most for a single intervention or bimodal intervention, focusing in tailored exercises for balance, gait retraining, or strength. Typically, in some, I would say, settings like here in Canada, are those patients that we believe they benefit for a physiotherapy referral or for the balance or gait retraining. And they benefit a lot for the educations for falls prevention. So this is interesting group. And of course, we have the typical high-risk group in where we redefine again fall severity, because in the past, fall risk group were those that have an injury or have 2 falls. But we found that evaluation of frailty was lacking in those algorithms. So we believe that people with frailty, and we're going to talk later on how we define frailty. If you have a fall and you are frail, there is a strong evidence for several longitudinal studies, particularly the TILDE study, showing that your risk of falls and injury increased 5 times. Interesting, if you have the first fall, but you're not able to get up, you're laying in the floor more than half an hour, that's considered fall severity for our peruse and the evidence. And also, if the fall can be related to a syncope, because that is going to drive recurrent falls. Those individuals at high risk should be offered a comprehensive assessment of fall prevention, where the majority in our group were physiotherapists, occupational therapists, social workers, and also geriatricians. One example is the comprehensive geriatric assessment, in where you address potential risk factors, and based on that assessment, you provide multi-domain interventions. And this group may need a close follow-up due to the recurrency and the risk of injury. So this group should be followed in a prudential time. The evidence shows that the prudential time should be 30 to 90 days. So as you can see, this is the new algorithm we proposed based on the evidence, and we redefine fall severity. Part of the key message that everyone agreed was that falls and injury prevention need to be addressed at the point of care and from a multidisciplinary perspective. And that's the reason some groups, particularly for the low and middle income countries, they stress the issue about opportunity case finding. Sometimes they were saying, you know, in our system, it's very difficult that the older adult get a consultation with the primary care physician, sometimes with the ears, but sometimes come to the emergency for other problems, you know, abdominal pain, fever. So opportunity case finding to try to address falls at the point of care is important in those settings in where annual health visits or follow-up by primary care doesn't exist. And that's important because if they come in with a fall or they have a fall history, sometimes after a fall, there is some stigma. And in some settings or countries, people, they believe that fall is part of the, you know, normal aging, so they don't go to visit the clinician or the doctor. Or for the stigma, they may be reluctant to report falls. So that's important when you detect that issue, should be addressed in the point of care. Particularly, as I said before, that have been highlighted for the low and middle income countries group, right? And that's important that tailored multi-domain intervention should be offered if you detect those participants or patients at a higher risk, right? The other key message of our guidelines is that engaging all the adults themselves in the plan to assess fall or to treat fall is an integral part of the preventing falls. And it's very important to understand their belief, attitudes, and priorities in order the intervention works. Why? Well, there is evidence for very well-conducted randomized controlled trial. If you involve the participant in the plan of the fall prevention, particularly if you involve the participant and the caregiver, the adherence to the treatment is better. So you need to ask them which kind of exercise they like, at what time, how we can do it, how with the transportation. Adherence in the intervention is improved. But also the attitudes and the beliefs about fall prevention of each individual, taking, you know, in very important the cultural background, and that was very well addressed. For example, in older adults, living in some Latin American countries in the Andes region, that they already there, with climbing mountains and everything, what kind of therapeutic interventions can help them more due to that environment to prevent falls. And again, there is no any doubt that caregiver involvement is key for those that have cognitive impairment, particularly those that have executive functions. The other key message we wanted to transmit here is that low risk does not mean no risk. And again, these guidelines, our guidelines have been developed by clinicians in general, but we have several discussions, right? That some kind of public health approaches. We didn't address this in this World Force Guideline 1.0, probably it's for our World Force Guideline 2.0, but some people say, well, probably a public health approach should be also addressed, right? Because we treat all the community, not only based on their risk stratification, but we treat based on how we build cities, how we build environment, because we do know that low risk doesn't mean no risk. As we said before, up to 30% of the community, older adults who fall, they don't have any history of previous falls, or they don't have gait balance problems. But importantly, 70% of those falls, up to 70%, 60 people here, may have an injury. So those falls are not benign. And that's the reason we believe that having this case finding system or screening algorithm should include those people, because in the past, those low risk, we do nothing, we reassess them. The conclusion for our group was that educations and general exercises should be offered to those with low risk. The other key message is that when we review all the interventions, the intervention that sticks all the time, the first is exercises. But exercise is medicine, right? And when I prescribe antibiotics, I don't prescribe antibiotics. I prescribe this antibiotic in this posology with this frequency and this dose. The same for exercise. We have a very strong and long chapter addressing this issue that was led by several international experts from Australia, UK, and also Canada, in where the evidence and our systematic review showed that the best exercise for fall prevention should include balance challenge. So should be exercise for sure involving the lower limbs. So you do just basic curling will not prevent your falls, involving the lower limb, but you need to challenge the balance. And some of the exercise can be done at home. The typical example is the sit to stand or the stepping exercises, but should be offered at least 3 times per week. Should be last at least 30 minutes. Should be progressive exercise, particularly intensity. And the period to do those exercise in order to prevent falls should be around 3 months, at least 3 weeks. Those exercises that were less than 3 weeks, we don't have evidence that prevent falls. Of course, you do more than 3 months, the effect is better, right? And that's very well explained and based on the evidence. This is a strong recommendation. And this applies to all older adults, regardless of their assessed risk of falling. We have some evidence that will be feasible. Tai Chi or others may have a role, like a resistance training strength, but again, is not as good as those that challenge balance of the lower limbs stepping. But it's important that the sufficient intensity and duration should be delivered that in ways that ensure safety, right, and consider function. The other key message was about multi-domain intervention, because perhaps you're familiar, around 2020 and 21, there were 2 very important falls and fracture prevention trials published in very high caliber journals, including the New England Journal of Medicine, that were negative, right? The particular were the STRIDE trial in US and the PREFIT trial in UK. And I will address this in the following slide. But the important data that we did in our systematic reviews, we did also a network meta-analysis with the group of Sharon Strand and Trico in Toronto and the group in Netherlands, led by Nathalie van der Velde, that we found that So far, all the multi-domain interventions, which is a combination of different interventions tailored to the patient based on the individual risk factors, when they are followed and delivered, they're very effective reducing falls. And they're very effective in reducing the rate of fall, particularly in intermediate high risk. And this was very important because after negative trials in some countries, particularly in UK, there were plays for the government, well, perhaps we don't need to invest anymore, in falls prevention clinics, whatever, because multi-domain intervention, they don't work. So, and just two definitions in order to understand the following slide, when we speak about multi-domain interventions, are those interventions that can address several domains, but they're individually tailored and delivered and modified and personalized for the individual. While a multi-component intervention is 2 or 3 interventions fixed, the same for everyone. For example, multi-component can be, we do exercise and medication review to everyone, while multi-domain is, we do exercise, but medication review only for those that have taken more than medications. We provide balance routine, those only have the imbalance problems. We provide hearing aids only in those that have hearing deficiencies, and so on. That's multi-domains, more tailored. So as I said, this network meta-analysis that was published by the group of Trico, Sharon Strauss, but also the Netherlands, show that multi-domain interventions reduce falls rate, but 13%, which is very important due to the magnitude of the problem. Interesting, the components of the multi-domain interventions that it seems provide the majority of the benefit were physical exercises, very well used the assisted technology, so the patient needs to know, the participant how to use the walker or the cane. Environmental hazard assessments, so to remove assessment and hazards at home, and basic fall assessments. Interestingly, this meta-analysis, when included the negative results of the PREFIT and the STRIDE trial, still didn't alter those findings. Still, fall prevention is important. And the main limitation in those STRIDE and PREFIT trial, and we have a special presentation about this in our group, was that they were not very well delivered. Particularly in the STRIDE trial, in the intervention group, only 30% follow all the recommendations because it was a pragmatic trial, right? So not all the recommendations were followed, and the same in the PREFIT. So basically, when we read the trial that is negative, we need to be sure that the per protocol analysis is clear and the interventions were followed and delivered. There were some key messages about falls in hospital and nursing homes, right? And basically, the main message is we don't do fall stratification there because everyone has risk of falls, right? We do know we use the Morse scale that help us to understand a little bit. Evidence showing that the scale doesn't change any outcome. And everyone should be treated when it's over 60 at high risk of falls because everyone is that, right? So basically, particularly in home cares, the multifactorial fall risk assessment should be done at admission in order to understand which are the potential deficits on areas to target. The cognitive status should be considered when we implement the strategies, right? Because it's not the same the patient in the lead and with cognitive impairment to implement those. Also, we recommend, or the group recommend, that when feasible, hospital or care homes should have protocols and procedures how to prevent falls. I know this in general in Canada is very well taken. We have all this in place. But also that promotion of exercise in those areas should be part of the multi-domain prevention intervention. So you need to choose 1 or 2 interventions should be, promotion of exercise and also medication review in those settings. The other key message is the issue about vitamin D. We couldn't find evidence that vitamin D works to prevent falls as a general recommendation. So the evidence is showing that vitamin D supplementation may prevent falls only if you have severe deficiency of vitamin D. So the main key message is that vitamin D supplementation to prevent falls should be reserved for those at risk of vitamin D deficiency or with vitamin D deficiency. There is a lot of controversy about several countries and settings. So we recommend you should follow local guidelines to assess vitamin D status in your community. Here in Canada, we don't recommend to do a blanket assessment of vitamin D status doing blood tests in people over 65. But if you are a high risk deficiency, you are, a very low functionality older adult in a home care, you're homebound or you're very, very frail, we don't measure. We supplement a standard supplementation directly because we do know your high risk is very prevalent, but also we know that the harm of regular doses around 1,000 units international per day is minimum. And evidence shows that vitamin D can prevent falls in those settings, mainly in residential care. And probably because levels are very low, vitamin D7 levels in those residents, right? The other key message I found very interesting, and that came for our polymedication and polypharmacy group, is that when we clinicians, we start prescribing a medication, so we're not thinking about it, we're prescribing medication to our patient, and that medication is known to be a fall risk increasing drug that we call FRID, we should think about fall risk before prescribing the medication. So if I need to prescribe, a benzodiazepine for severe anxiety, before prescribing it, what's the risk of fall of my patient? Why? Because it's very difficult to prescribe something. It's very difficult to de-prescribe. In general, we don't want to de-prescribe. We want to go slow. We don't want to over-challenge a prescription for other colleagues. So we have a responsibility before prescribing medication that we are known to be are higher risk of fall or FRID, so fall risk increasing drugs, to think about the risk of fall and perhaps not prescribe the medication and to look for an alternative. And this group shows for the meta-analysis that the strong evidence is in place to demonstrate that structured approaches using algorithms to detect that improve FRID identification and medication review. And that should be done, for example, in settings where we know people have polypharmacy, like in nursing homes. Here in Canada, it's very well established, the medication review committees in nursing homes. And there are several medication review tools suitable to systematically identify these FRIDs and to optimize prescribing, but also to optimize de-prescribing. So we have, and we propose in our guidelines, several algorithms how to prescribe, benzodiazepines or anticholinergic medication or medication that may affect blood pressure. And of course, this is a must in long-term care homes or residents, right? As I said before, in hospital and home care, everyone should be considered high risk, and multi-domain intervention should be tailored to everyone. And I think we've already saw this slide. Importantly, we address a little bit the issue about hip fracture. And there is very, very strong evidence that after hip fracture, you have already a program in place in order to provide rehabilitation. And we have several examples here, like the ortho-geriatric liaison or the post-hip liaison. Here in London, Ontario, we have a GRU, Geriatric Rehabilitation Unit, with everyone after a hip fracture and got the surgery after 2 days in the hospital come to us, to the geriatrician. So he's spending 1 or 2 days only with the ortho surgeon. If we provide individualized progress exercise program, they do better, they recover better, and they have less falls. So these programs should be commenced in the hospital. And you have a liaison, use the liaison. And if you don't have the liaison, try to create it. The evidence is moderate. This evidence aligns with several guidelines from the WHO. The other key message is that perhaps this recommendation will have several challenges that may not be applied in needs or low middle income countries. So they found that, for example, they need to use different cultural sensitive strategies and to local level of expertise. I will say this may also be true for specific communities. We didn't have a working group doing that due to the lack of resources, but for an indigenous community, we know a little know a lot about falls or medical conditions in those communities. Interestingly, falls rates are increasing dramatically in low middle income countries. And when they look for risk factors, it seems that a specific risk factor like obesity, low cognition, and diabetes are key in those countries. Where, for example, here in Western countries, obesity is other risk factors associated with the other ones. But here we're quite specific, particularly in some countries, the below middle income. So that was quite interesting, right? And also we provide some recommendations which tools they can use in those countries in where resources are not available all the time. And just to try to wrap up, to give 15 minutes for questions, which are the limitations we have in these guidelines, and what are the next steps? Well, we try to have a worldwide representation, and you see our map in our website, worldforceguideline.com. You can see we have several countries. However, one continent, Africa, was underrepresented. We couldn't get a lot of representation for that. Also, we're very proud we create this panel of all the others that peruse our evidence, but there's a bias there because this panel was composed for 7 countries individuals. The majority were English speaking because English was the lingua franca we use in this international consensus, as today is the lingua franca in business and in medicine. And yes, and in research medicine, it's English, you know. And in business, all the transactions and the wire transfers are in English. So again, the lingua franca was English, but that, and also were for countries, the high income nations. I think we have some representatives for Malaysia, but Malaysia is considered also now becoming considered a high income nation. So probably we lack of diversity in our feedback. So for next step of Workforce Guidance for 2.0, we should address this issue. We should have more diversity in our panel of adults. And the other point is that our recommendations that you're going to see, a specific recommendation, our guidelines, but also the accompanying algorithm that I try to walk you through, are very pragmatic and then to me easy to apply and adaptable to other person's needs in different scenarios. But we didn't test formally the algorithm and we didn't do a validation. Although previous algorithms were not validated either, but an algorithm should be validated, right? So that's the next step for our Workforce Guidance 2.0. We try to address areas with knowledge gaps were detected, particularly technology. We're very keen, you know, to look how we can use wearables, how we can use technology. Unfortunately, everything was still too scarce to provide strong recommendations. So we provide some recommendations, mainly research recommendations, but we couldn't provide a strong recommendation. Yes, use the Fitbit, the wearable to prevent falls, or the digital technology. The evidence is not there yet. The evidence is not there yet. We peruse the evidence. You're going to see a long chapter about e-technology and wearables, but the majority of recommendations are how to use this in clinical trials and which outcome to use, because the evidence for general population is not there yet. And the same goes about research and implementation. There is a lot of lack of research implementation. So how we can implement all this with the toolkits? We have toolkits, but let's see how this works in real scenarios. So the guidelines are alive, and I really want to acknowledge my writing committee. So besides the 300 people, these individuals here for several countries, they work almost every day for 6 months while we get all the peer review process to get our guidance published in Age and Aging. That was a very, I will say, tight deadline, close peer review process. We have gratitude to Age and Aging that was able to create a panel of peer reviewers that were providing feedback in 1 week, and we need to return the feedback in 3 days, and 1 week and 3 days. And that was for several months in order to get this international guideline published. But that is the work of those guys. I'm only the face presenting this as the chair of this endeavor, but this is the work of those guys here in the writing committee. And I was part of the writing committee too. So again, the guidelines are alive. I want you go to read the guidelines, to give the recommendation, to get your feedback. And now I want to acknowledge all the central committee that was sponsored by grants from CIHR. We got the planning grant from CIHR to do this guideline, and also from the St. Joseph Foundation in London, that support all this staff, the part of my lab in central London that worked 3 years, that was central staff working this guideline, and all the societies and organizations and agencies that already provide endorsement to our international guidelines. And I think I have here my website, or our website, the Workforce Guidelines, where you can go, and my email for any questions. And I finish my presentation with this. I'm open to any question you may have.
Thank you so much, Dr. Montero-Odasso. We want to thank you so much for your time today. We know it's very valuable and we're very grateful. And it's exciting to see almost 500 people online today to discuss this important global initiative. The amount of work that went into these guidelines is very clear, and it is truly a collaborative approach. So thank you again. We did have a few participants submit their questions through our Q&A box, so I will address those momentarily. But first, I'll take over screen sharing, and I'll put, I've got your contact info there too, so folks can jot it down if they need. But just to go over one last housekeeping item is that when the webinar ends, everyone will be directed to an evaluation survey, so please fill that out. We really appreciate the feedback, and we use it continually to continue to put on some good programming for everyone in the community of practice. And a reminder, if you aren't a Loop member already, there's no cost to register. It's only a win-win for you to gain more knowledge and share with your colleagues and connect with those who are also working in the realm of fall prevention. So I'm going to move on to the questions, and I'm just going to go through them chronologically. The first one we received, I'm not sure, there might be a word missing, but it says, how applied programs for fall prevention to nursing home residents? So I'm wondering if it's saying, how were programs applied for fall prevention to nursing home residents? Yeah, I'm not sure if we need a little bit more context with that one.
Well, no, it's okay. Implementation all the time is a challenge. Although I will say for nursing homes, it's easier if you have the resources, because there are several guidelines how to implement that. So, and particularly here in Canada, in general, some nursing homes, and I was the leader of the, with my colleagues at McGill, when I was at McGill University, I was the leader of the fall prevention program in the Maimonides Geriatric Hospital in Montreal, and that program received the 3M Quality Prize in Canada, and we created a protocol. So basically, when you have a very well-established protocol in where you know everyone is at risk, you can do further stratification, you divide in wards, so with cognitive impairment versus no cognitive impairment, you have a medication review, you have a pharmacist involved, you have a multi-domain approach. From the beginning, you do the comprehensive assessment to detect false risks, you can implement that. And we provide tips in our guidelines with links with programs that are successful. The key issue here all the time is resources, because this means funds and personnel, so human resources and money. And again, we try to provide those toolkits in our website, but also in our guidelines. But there are several examples of guidelines or implementation, how to do the program. I hope I respond the question, but in general, it's very well, I would say, establish how to do in nursing home. The problem all the time is resources, funds, and human resources. On the other hand, sometimes a little more challenge to apply all this in the community, right? Because we have sometimes lack of continuation of care. Some people don't have family physicians and so on. Sometimes very more challenge in the community.
Yeah, absolutely. Thank you. Our next question was the importance of healthy eating and good hydration included as an intervention? I agree with the regular exercise, medication review, etc., but poor diet and dehydration may also affect the frequency of falls. Wondering if you have a comment.
That's totally right, for sure. As having diabetes or having obesity, the thing is the following. When you look for a single intervention in the community, there is no evidence that healthy diet or hydration improves or reduces rate of falls, while for exercise there is. However, In the comprehensive genetic assessment, where you're a high fall risk, right? So we need to devise about the different, I will say, scenarios and the different target population. In those high risks, yes, you do the comprehensive genetic assessment, and part of the comprehensive genetic assessment is to detect medical conditions. And if the patient is having fever or dehydrated or is malnourished, for sure that will contribute, for example, to sarcopenia or lack of strength, and will, I would say, increase the risk of falls. But that is part of the comprehensive genetic assessment. As an individual intervention, because in general those that have malnourishment or dehydration are those at higher risk. As a single intervention, there is no evidence they work. The only single intervention that there is evidence that works is exercises. Doesn't matter all the problems you have. But very excellent diet and correct the deficit in the multi-domain intervention is a key part and works perfectly. Yes.
Great. All right, a couple of questions came in around vitamin D, all kind of asking the same thing. So I'll just read one regarding vitamin D. Well, the key message is that it's recommended for those with a deficiency. Was there consideration given to injury prevention where calcium and vitamin D together can impact bone strength? If so, is there a recommendation or a reference you would suggest?
Yeah, this is a very important point. So just to put this in perspective, suppose you're a family physician or a clinician and you see a person over 60 coming to your office and you detect that patient is at low risk of falls. There is no blanket recommendation to provide vitamin D. If you do in a scale, the screen like the Frax scale, and the patient or that person may have osteoporosis, or particularly women that have postmenopausal osteoporosis, yes, the recommendation of vitamin D and calcium supplementation is not for falls prevention, it's for osteoporosis. That will help later on to get bisphosphonates if they need it, or other bone strength medication, and to prevent the injury to falls. So yes, if the patient has a risk of osteoporosis, should receive vitamin D or and calcium. However, just for falls prevention, in a relative good functionality, healthy, or with established comorbidity over 65 that come to your visit, there is not recommendation of vitamin D as it was before. Because before, we believe for the evidence that vitamin D supplementation may have a therapeutic or pharmacological effect. Different is that in countries like Canada, that we don't have sun for 6 months per year, our older patients or our older clients should have a very diverse diet with good amount of food that provide vitamin D. So this is a global recommendation in the annual health visit that should be conveyed very clearly. And we do that with our patients. So the vitamin D should come from the nourishment or for the diet. But taking vitamin D as a medication, a supplementation, not complementation, unfortunately, there is no evidence that prevents falls. And I have done a lot of research on vitamin D, and I was one of the vitamin Dists that I thought there will be a supplementary effect on pharmacological effect of higher dose of vitamin D. Because, and that is related to other question about vitamin D that I read very quickly in the question and answers, because, for example, we do know, for example, that when you have severe vitamin D deficiency, you increase your level of PTH. And when your ratio vitamin D or 25-hydroxycholecalciferol and PTH ratio in the plasma is reversed, so you have more PTH and low vitamin D. The PTH is toxic for the muscles and create, for example, osteomalacia. That we don't see anymore because fortunately we don't have that huge deficit of vitamin D in children. But in other adults, they may affect the muscle function. And there is some evidence this huge vitamin D deficiency plus the high PTH is toxic for the muscle and may one of the culprit sarcopenia. So that provides to us, some scientific rationale. Okay, let's give high dose of vitamin D because that will prevent, muscle mass wasting, and so on and so on. And we did several trials. I conducted trials. I got CIHR grants, and all were negative. Unfortunately, I couldn't find evidence, and others couldn't find evidence. In fact, some studies have shown the higher doses, and that was just published in Annals of Internal Medicine last year, and we covered that in our review, is detrimental. So giving higher doses give more falls. And we don't know why. And it's very interesting and several theories about that. So today, if you are a healthy older adult or with comorbidities established, you're not frail, you don't have sarcopenia, you're not high risk of deficiency because you are all day in a nursing home, there is no indication of vitamin D supplementation to prevent falls. That's the key message.
Thank you. We are at time. If you have time for one more question, it's a good one, but if not, just let me know, Manuel.
Sure, I have time. No problem.
All right. So this one is, thanks for this informative summary and for being part of the genesis of this work. Wondering in the work, was there review done on the use of specific assistive devices for fall prevention? Examples, grab bars, bed rails, floor to ceiling support poles, and their location of install within the daily living spaces?
We have, yes, that's an excellent question. We have a group working in that, but that is not part of the Workforce Guidance 1.0. That is going to be part of our next step with this Workforce Guidelines 2.0. You can go to our website, workforceguidelines.com, and there is a group about assisted devices and technology, and they're working in that. But that's an excellent point. And now I would like to acknowledge, for example, one of my colleagues, my former postdoctoral fellow, Dr. Susan Moore. Now she's faculty member here in Western, but she was my trainee and my fellow. With her, we have done very interesting work, and she was the leader of that work, about assisted devices, because this question is quite pertinent because, for example, walkers, very complex walkers today can be an executive function challenge because you need to know how to use the walker, how to do the brakes. And it's not uncommon if you have people with severe executive function or cognitive impairment, they struggle how to do it. They brake when they don't need to brake, and they fall because the bad use of the assisted device, right? And sometimes we don't know how to prescribe because there is a training how to prescribe an assisted device, right? So that's a very important point. Was not addressed in this guideline. We had some research done. Susan Moore Hunter had done some research when she was my trainee, and I think she continues now. But that is an area we're going to address in the Workforce Guidance 2.0. But also, there is some mention in the long guidance that, again, they're open access. So you put Workforce Guidelines and Montero-Odasso, my same name, it will appear in Google. You click to the link, you have the full guideline, the 33 pages of the paper, but also access to the supplements, the 200 pages detailed guidance with all the details.
Great. Thank you. We do have other questions, but we are at time. So
for me, guys, it's not a problem. I already booked this time. You know, I know Michelle and Helen worked very hard to get this. So if you want to keep doing questions, I'm okay for the next 10, 15 minutes. Otherwise, awesome. If you have other activity, also I'm okay to close now.
Sounds good. Then let's keep going. And then we can have these answers on recording for those who do have to leave. So that's fantastic. Thank you, Manuel. The next question, are there indicators on the recommended timeline for starting community/outpatient fall prevention programs post-discharge from hospital or inpatient rehab? Current wait times post-discharge can be as much as 2.5 months.
That's an excellent question. And our algorithm establish that if you detect in the case finding opportunity someone at high risk of falls or have a severe fall, the follow-up should be between 30 to 90 days, no more than that. Because we do know the probability to have a new fall and a fracture is very high. And the evidence is very strong about that. Of course, that depends on the resources of each system, right? But that is the overall recommendation. So those high-risk individuals should be seen again to implementation to see how it's working in a prudential time of 30, 90 days. Some countries, Australia is doing very well about this. Here in Ontario, I think I'm sure in McMaster, we don't have that in Western yet. We have pledged a lot to get this. We have some liaison, right? And a key liaison is the emergency department, because sometimes here in our country, emergency department is the first point of contact after a falls, a fracture, because you cannot reach your GP, or there is a waiting list and so on. And some countries like Australia have created liaisons. When someone is coming with a fall, a nurse is going to do all this assessment and already make the appointment for the falls fracture clinics or something like that in 30 days or in 60 days. This liaison, I think, is key. We have tried, and we're pledging to do that here in Western, because we believe that is key, and that will offer a better care for our older individuals, right? But Australia have done very well in that. Here in Ontario, still we have room to improve.
All right, the next question is Ontario specific, rather, and it says, how can we apply this information in a hospital setting like in Ontario, where we have gone to such great lengths to prevent patient falls, but also results in less mobilizing of senior patients outside of when patients are seen by physio and staff?
I think that is key, and if you go to our recommendations, we address the issue about exercises and mobility. Part of the treatment is mobilize the patient. Is available the mobilization. We have a project here in London and Western Europe that was the Move On project, and we have that project. We train our nurses to walk our participants, to mobilize them. We have volunteers helping us, and work perfectly, and we reduce the falls. And later, we finish the project. I think they got a nice report. I was not, I would say, incorporating the clinical practice. We don't do that anymore. So it's challenge. It's challenge. It's politics. It's challenge. It's evidence. It's resources. But you're totally correct. Should be not only to prevent immobilizing the patient. Should be only having the human resource to help the participant to mobilize under supervision by the trained volunteer and a trained POW. We have had some challenges also with COVID, in where we couldn't have volunteers anymore, we couldn't have SPOWs anymore. So it's a challenge. And the physiotherapist doesn't have the time. Either one physiotherapist for the ward or for 2 wards, they need to see several patients. It's a challenge. The evidence exists how to do it. The problem is the implementation. And I think the future step in all this, like several things in medicine, is research about implementation. Which are the gaps to implement that? Which are the barriers? We have this evidence, why we cannot implement it? What is not working? Why it work when we got the Move On project and we don't do anymore? Well, because we don't have the funds, we don't have the money, we don't have the champion. You need to detect the champion, someone that was keen to do that, and so on and so on.
Yeah, absolutely. This one's an interesting one. Have you considered sensory changes like vision and hearing in developing these guidelines, since it is a major risk for falls? Totally. And there is a chapter about that. We didn't address in a specific working group because there was no gap, because that was very well established, right? That was very, very established. So the 14, so the 12, initially 17 working groups were more created, as said before, based on our systematic review publishing in JAMA, based on the gaps. But there is no any gap about that sensory deprivation, mainly hearing and visual impairment, are key factors that need to be corrected. And the expert group, we provide some expert recommendations there based on previous guidelines, because the evidence is still strong. For example, we do know that, for example, cataract surgery works, to prevent falls. We do know that bifocals can be decremental because increased falls, because the patient may be confused with the bifocals. So that's in the guidelines. Yes, that's addressing the guidelines. Thank you. Alrighty. The next question here is, what if patients are non-compliant to their medications that makes their risk of falling higher? For instance, a patient came in with a fever, COVID related, but had underlying heart disease, but didn't take their meds all the time. He came into ER and collapsed and fell. His fall was unwitnessed, and unfortunately he passed away. That's a classical high-risk, frail individual. Probably, I don't see the patient, but probably that the individual has some level of frailty. That individual has a higher fall.
So those are the patients or individuals that benefit the most for this comprehensive assessment. We call, because I have a bias, I'm a geriatrician, comprehensive geriatric assessment, but basically it's a comprehensive assessment in where you address which are the established factors, but which are the triggers. The triggers in this patient was an acute medical condition, COVID infection, that make the patient confused, didn't take the medication, and got the CHF exacerbated, and came for CHF and got the syncope and passed away. Yes, those patients benefit for the comprehensive assessment because the fault in this individual is the tip of the iceberg of all the medical conditions are affecting this individual.
Great, thank you. And so I'm going to put our last question up to you. This is there a recommendation as to where the rehab should continue post-hospital in the community, outpatient program or at home?
Yes, that's on our guidelines. Because basically, depends what kind of rehabilitation we're talking. If we're talking about geriatric rehabilitation after being the condition in the hospital or after a fall, you establish goals. And based on those goals, you reach those goals. And perhaps because resources are scarce all the time, you provide a timeline about the rehab, few weeks. However, general recommendation of physical exercise that challenge lower limb are universal recommendations that should be followed for everyone. Now we are working, particularly because I'm a team leader in the Canadian Consortium of Neurodegeneration and Aging. I'm very interested in falls and cognition. My books are about falls in the cognitive impaired, falls and cognition. We're very interested in how we can implement this continued exercise safely at home, using Zoom technology, so we're working in that. But yes, so besides the goals that you establish with your colleagues, with your occupational therapy, physiotherapy, social workers, and you establish the goals about which level of functionality or exercise you want to reach, ongoing physical exercise, as little as half an hour 3 times per week, challenging lower limb, like a sit-up and stance, safely done, can be enough to maintain those gains. Because that's true, you know, with all this rehab, they go home to do nothing, they're sitting all the time on the couch, they will come back with more decondition and falls again.
All right, thank you so much again, Dr. Montero-Odasso. Really thankful for your time. It was great to have you for a little extra time to answer those questions. I know those on the line are very grateful, and those who will be watching the recording are very grateful. So thank you again, and thank you to your entire team who put these together. It's, like I said before, it's clearly truly collaborative approach, and it took lots of people power to put it together. So thank you for this, and we look forward to speaking with you again.
Thank you, guys. Visit our website.
Absolutely. Bye-bye. Circulate that with the post-event package.
Yes. In fact, in my presentation that I gave it to you, you want to circulate, there is the links to the website and to the papers.
Fantastic. Thank you again, and have a great afternoon, everyone.
Bye-bye, guys.
Bye.